So my name is Cheah. I'm a consultant haematologist at Sir Charles Gairdner and Hollywood Private Hospitals in Perth, Western Australia. So the question is what proportion of patients with follicular lymphoma relapse and how do we manage them? Ultimately, in contrast to diffuse large B-cell lymphoma, most patients with follicular lymphoma the lymphoma will eventually return. The exception to that is the minority of patients who have limited stage disease. Say if we take a patient with symptomatic advanced stage follicular lymphoma who's treated with a standard chemotherapy program like CHOP with either rituximab or obinutuzumab, long-term studies suggest that the average time that the lymphoma stays away is probably somewhere between 7 and 10 years, depending on the study. But eventually, at that 10-year mark, then about half of patients will have had their lymphoma return. There are many options for the treatment of patients with relapsed follicular lymphoma. The way that we decide, firstly, not all patients with relapsed follicular lymphoma require treatment. We use many of the same criteria that we use in the frontline setting, these GELF criteria which I mentioned, the presence of symptoms, to determine whether or not relapsed follicular lymphoma needs to be treated. If it's just present in a couple of sites in the body and it's not causing any symptoms, then we can safely observe patients just as we can in the frontline setting. In terms of patients who do have symptoms and the follicular lymphoma has returned, there are many options, and the best treatment will really depend on the age and fitness of the patient and the availability of clinical trials. The one area where there is a little bit more clarity about what to do is patients who experience early relapse. That's within 2 years of their 2 years of their initial diagnosis of follicular lymphoma. Around 20% of patients with follicular lymphoma will have it return within 2 years of their initial diagnosis. So they're diagnosed, they undergo treatment, which normally takes 4 to 6 months, and then sometime in that next little short time period, the follicular lymphoma returns. Now, for those patients, we know that is a risk factor for a worse outcome overall, and that there are some registry studies suggesting that younger, fitter patients who are in that situation should probably have second-line chemotherapy followed by an autologous stem cell transplant. So that's something which is slightly clearer compared with the later relapses, where there are a lot more flexibility in terms of treatment options. So the question is, what is histologic transformation of follicular lymphoma? Transformation of follicular lymphoma is a rare event where a patient who has follicular lymphoma initially later has a rapidly growing lymph node, which when we do a biopsy shows a large B-cell lymphoma. In other words, the lymphoma has transformed from a slow-growing lymphoma to a fast-growing lymphoma. In the modern era with rituximab-based chemotherapy regimens, this is fortunately now becoming a less frequent event. It seems that the more rituximab that you get in your initial treatment, the lower your risk of transformation. Recent studies suggest that patients who get rituximab with a chemotherapy and rituximab maintenance over about an 8 to 10 year period probably only have a risk of transformation of around about 3 to 4%, which is lower than what we previously thought. It used to be, the thinking was, before we had rituximab, that risk of transformation was probably about 10 to 15% over a 10-year period, but it seems to have been reduced. The implication of finding transformed lymphoma is different to finding follicular lymphoma. We generally tend to approach this with more aggressive treatments, and that will often include CHOP if patients did not receive CHOP as their frontline follicular lymphoma treatment. If they did receive CHOP in the frontline setting, then we would use generally some other kind of second-line treatment, and for patients who are fit and who are able to undergo a transplant, we would often consider that as well. So the question is whether patients who have relapsed follicular lymphoma should undergo repeat biopsy. And the answer to that is almost always yes. So wherever it's safe and feasible, it is desirable to obtain another biopsy. And the reason for that is to make sure that patients don't have transformed disease. So a proportion of patients can undergo transformation to high-grade or large cell lymphoma, and the treatment of that is sometimes different. And it's also possible for patients who appear to have relapsed lymphoma have some other problem like inflammation, so some other reason for their lymph node to be enlarged. So we always try to obtain a biopsy whenever it's possible before starting second-line treatment.